Welcome back to First Aid Neurology, brought to you by Falcon Physician Reviews. In this section, we'll cover neuropharmacology. We'll begin with glaucoma. There are a number of neuropharmacologic agents that can be used to treat glaucoma. For example, we can use alpha agonists, beta blockers, diuretics, cholinomimetics, and prostaglandins. In the alpha agonist class, drugs like epinephrine and brimonidine can be used, both of which will diminish aqueous humor synthesis via vasoconstriction. Epinephrine can cause mydriasis, can cause stinging of the eyes, and you don't want to use this particular drug in closed-angle glaucoma, which can be worsened by the use of epinephrine. Brimonidine is not associated with any pupillary or vision changes. Timolol, betaxolol, and carteolol are all associated with decreased aqueous humor secretion, which can decrease intraocular pressures, and none of these drugs are associated with pupillary or vision changes. Acetazolamide, which is a carbonic anhydrase inhibitor, will decrease aqueous humor secretion. This drug is also not associated with pupillary or vision changes. Drugs that are agonists to the muscarinic receptor, such as pilocarpine or carbachol, or indirect agonist, meaning drugs that elevate acetylcholine levels like physostigmine or ecothiopate, will increase the outflow of aqueous humor by contracting the ciliary muscle and opening the trabecular meshwork to allow aqueous humor to flow. You can use pilocarpine in emergencies, and it's very effective at opening the meshwork into the canal of Schlemm. The side effects of this class of drugs are miosis and cyclospasm. Prostaglandins, such as latanoprost, which is a PGF2 alpha analog, will increase the outflow of aqueous humor. One notable side effect here is that this drug can cause darkening of the iris, a process known as browning. Another important class of neuropharmacologic agents is the opioid class. Herein we have drugs like morphine, fentanyl, codeine, heroin, methadone, meperidine, and dextromethorphan. The mechanism here is to act as agonists at the mu-opioid receptors primarily, although these drugs will also act at other receptors such as the delta and kappa opioid receptors. The mu receptor is most specific for morphine, delta for enkephalin, and the kappa for dynorphin. These drugs will modulate synaptic transmission. They'll open potassium channels, close calcium channels, and thereby diminish synaptic transmission. This will inhibit the release of acetylcholine, norepinephrine, serotonin, glutamate, and substance P. Clinically, the most common use for these drugs is to treat pain, although many of them are very good cough suppressants, such as dextromethorphan, and certain drugs work primarily on the GI tract to slow it down to treat diarrhea, such as loperamide and difenoxylate. Pulmonary edema can be decreased by virtually all of the opioids, and certain opioids that have a slower onset and offset of action, like methadone, can be used for maintenance programs for opioid addicts. The major toxicity here is addiction. Acutely, respiratory depression can be life-threatening. Most of these drugs will cause constipation. The constipation tends not to be a side effect that goes away over time. These drugs can also cause miosis to the point of causing pinpoint pupils. One exception to this rule is meperidine, which has a metabolite with anticholinergic properties and can actually cause mydriasis. These drugs are also additive when it comes to their pharmacodynamic effects with other CNS depressants. Tolerance does not develop to the miosis and constipation, and toxicity can be treated with mu-opioid antagonists such as naloxone or naltrexone. Butorphanol. Butorphanol is a mixed agonist. It's a partial agonist at the opioid mu receptors and an agonist at the kappa receptors. The drug can be used for pain control because it does have some agonist properties at the mu opioid receptors, but tends to cause less respiratory depression than full agonists because it's only a partial agonist. Now, if a patient already has a large amount of a mu opioid agonist on board, because these drugs don't fully activate the mu opioid receptor, they can actually initiate or precipitate a withdrawal response in these patients. Tramadol. Tramadol is now commonly used for pain. It's a very weak opioid agonist, but it also inhibits the reuptake of serotonin and norepinephrine, and therefore it will increase the levels of norepinephrine and serotonin at the synapse. Since it works on multiple neurotransmitters, you can associate the word tramadol with tramadol in. The drug is primarily used for chronic pain, and the toxicity of this drug is similar to the opioids, with the addition that it can decrease seizure threshold. Epilepsy drugs. There are a large number of epilepsy drugs with different indications and different mechanisms of action. For example, phenytoin is a very commonly used drug. It's used across a broad spectrum for both simple and complex seizures. It's a first-line drug for tonic-clonic seizures, first-line drug for the treatment and prophylaxis of status epilepticus, and it works by blocking sodium channels. Particularly, it acts on sodium channels that are not in their resting state. One note is that phenytoin itself, when it's infused, is infused at a very high pH. Fosphenytoin can be infused at a more normal pH and therefore can be infused more rapidly. Fosphenytoin is converted into phenytoin in the body. Another popular anticonvulsant is carbamazepine, also works on simple and complex seizures. A first-line drug for tonic-clonic seizures, also works at the level of sodium channels and has an additional indication for the treatment of trigeminal neuralgia. Lamotrigine is another commonly used anticonvulsant, works for both simple and complex seizures. It's also used for tonic-clonic seizures, and it acts by blocking voltage-gated sodium channels. Gabapentin, also used for both simple and complex seizures, also used for tonic-clonic seizures, was designed as a GABA analog, primarily works by blocking the high-voltage activated calcium channels on neurons. The drug is also frequently used to treat peripheral neuropathy. Also, it's used as a mood stabilizer in bipolar disease. Topiramate, another broad-spectrum drug, both simple and complex seizures, also used for tonic-clonic seizures, blocks sodium channels, and probably increases GABA function. Phenobarbital is a drug that's been around for a long time, still commonly used in children, good for simple and complex seizures, good for tonic-clonic seizures. It's a GABA-A potentiator. It's the first-line drug still in children, and the drug can be used in pregnant women. Valproic acid, used for simple and complex seizures, first-line drug for tonic-clonic seizures, can also be used in absence epilepsy. The drug may increase sodium channel inactivation. It also may increase GABA concentrations. And of note, the drug can be used for myoclonic seizures and is probably first line for that indication. Ethosuximide is quite a unique drug because it has a single indication. Its only indication is absence epilepsy, and the reason is it works pathologically on what is thought to be the source of the epilepsy, and that is abnormal T-type calcium channels in the thalamus. Benzodiazepines are used for status epilepticus acutely. These are often the first-line drugs for this kind of seizure. These drugs are GABA-A potentiators, and they're also used for other forms of seizures, such as those seen in eclampsia. Recall that the first-line treatment for eclampsia-related seizures is high-dose magnesium. Tiagabine is also used for simple and complex seizures. It blocks GABA reuptake. Vigabatrin was recently approved for the treatment of complex and simple seizures. It works by irreversibly inhibiting GABA transaminase, which increases GABAergic levels. Then finally, levetiracetam, used for both simple and complex seizures, also for tonic-clonic seizures. It's not entirely clear how this drug works. It may modulate GABA and glutamate release. Certain epilepsy drugs are associated with particular toxicities. For example, benzodiazepines are well known to cause sedation. There's a high tolerance to their effects, and these drugs can cause dependence. Carbamazepine can cause diplopia, ataxia, blood dyscrasias such as agranulocytosis and aplastic anemia, liver toxicity. The drug is teratogenic. It can induce cytochrome P450, including the cytochrome P450 that metabolizes carbamazepine, so it is an auto-inducing drug. It very commonly causes a mild form of SIADH, and it has been associated with Stevens-Johnson syndrome. Ethosuximide can cause GI distress, fatigue, headache, urticaria, and Stevens-Johnson syndrome. One way of recalling these side effects is the mnemonic EFGH, ethosuximide, fatigue, GI, and headache. Phenobarbital as a barbiturate can cause many of the same side effects as benzodiazepines, that is, sedation, tolerance, dependence. In addition, this drug tends to be a potent inducer of cytochrome P450. Phenytoin is associated with nystagmus, diplopia, ataxia, sedation, gingival hyperplasia with long-term use, hirsutism, megaloblastic anemia, teratogenesis, which has its own name, the fetal hydantoin syndrome. It can cause an SLE-like syndrome, and the drug is a well-known inducer of cytochrome P450. Valproic acid can cause GI distress. One notable side effect here is rare but fatal hepatotoxicity, so one needs to measure LFTs for patients on this drug. Neural tube defects in the fetus. The most common type would be a spina bifida. Tremor and weight gain are very common, and this drug is contraindicated in pregnancy. Lamotrigine has been associated more so than other anti-seizure drugs with Stevens-Johnson syndrome. Gabapentin can cause sedation and ataxia, and topiramate can cause sedation, is well known to cause mental dulling, kidney stones, and weight loss. You may have noticed that many of these drugs are associated with Stevens-Johnson syndrome. Stevens-Johnson syndrome is associated with a prodrome of malaise and fever, followed by a rapid onset of erythematous and purpuric macules, oral, ocular, and genital. The skin lesions progress to epidermal necrosis and sloughing of skin. In the next set of slides, we'll review the major mechanistic and clinical features of the epilepsy drugs. Phenytoin, as mentioned before, is a broad-spectrum and commonly used anti-seizure drug. Its mechanism is use-dependent blockade of sodium channels, which will increase the refractory period of neurons, and inhibition of glutamate release from excitatory presynaptic neurons. The clinical spectrum is broad. The drug is used commonly for tonic-clonic seizures. It's also used as a Class 1B antiarrhythmic. Classically, the toxicities associated with this drug are nystagmus, ataxia, diplopia, sedation, a lupus-like syndrome. As mentioned before, this drug is a well-known and potent inducer of cytochrome P450. Long-term use can produce a unique side effect of gingival hyperplasia in children. It can also cause peripheral neuropathy, hirsutism, and megaloblastic anemia, relatable to a decrease in folate absorption. And the drug is also a well-known teratogen with its own syndrome known as fetal hydantoin syndrome. Barbiturates. There are several drugs in this class, such as phenobarbital, pentobarbital, thiopental, and secobarbital. These drugs are thought to potentiate GABA-A action by increasing the duration of chloride channel opening in response to endogenous GABA. This will hyperpolarize neurons and decrease neuronal firing. The clinical use for these drugs is not only for seizures, but also for anxiety, insomnia, and for induction of anesthesia, primarily fast-acting drugs like thiopental. The major toxicities here are dependence. They can cause additive CNS suppressive effects with other CNS depressants like alcohol. They can also depress respiratory function and cardiovascular function. Both of these could be life-threatening. There are also multiple drug-drug interactions because these drugs tend to be cytochrome P450 inhibitors. In overdose, there is not a direct antidote for these drugs. You would manage the symptoms, for example, assistance with respiration and with blood pressure control. These drugs are contraindicated in porphyria and can in fact unmask latent porphyria because they will increase the production of the substrates of heme. One way to help you remember the mechanism of action of these drugs is the word barbiturate, because this tells you that these drugs will increase the duration of action of the chloride channel. Benzodiazepines are an extremely popular class of drugs because they have a broad spectrum and tend to be safer than the barbiturates. Drugs in this class are diazepam, lorazepam, triazolam, temazepam, oxazepam, midazolam, chlorazepam, and alprazolam. These drugs are also GABA-A potentiators, but they work in a slightly different fashion than the barbiturates. While the barbiturates will increase the duration of chloride channel opening, these drugs will increase the frequency of chloride channel opening. Again, this has to occur in the presence of GABA. One way to help remember this is the mnemonic frenzodiazepines, because these drugs increase the frequency of the channel opening. These drugs will also diminish REM sleep, so although they tend to put people to sleep, they don't induce the normal structure of sleep. Many of these drugs have long half-lives and active metabolites. Clinically, these drugs are used to treat anxiety, to treat spasticity. Certain of these drugs can be used effectively to manage status epilepticus, such as lorazepam and diazepam, and as such have become the first-line drugs for status epilepticus. These drugs can be used to manage alcohol detoxification, particularly when it manifests as delirium tremens or DTs. They can be used to treat night terrors, sleepwalking, and can be used as general anesthetics because of their amnestic and muscle relaxation properties. These drugs are also good hypnotic agents, that is, they can cause people to go to sleep. The major toxicity of this class of drugs is dependence. In addition, these drugs can cause CNS sedation, and when combined with other sedatives, these effects can be additive. There is less risk of respiratory depression and coma than with the barbiturates. That's become one reason why these drugs are more popular than the barbiturates for similar indications. In addition, there is an antidote for these drugs. When there is overdose, the antidote is flumazenil, which is a competitive antagonist at the GABA benzodiazepine receptor. There are multiple drugs in this class. Certain of them are very rapidly acting. The mnemonic TOM-THUMB, TOM for triazolam, oxazepam, and midazolam, can help you to memorize the three most addictive drugs in this class, and the reason they are so addictive is because of their rapid half-life. Mechanistically, benzodiazepines, barbiturates, and alcohol are all highly related because they all work at the same point of the synapse. They all potentiate chloride flux through the GABA-A channel. In addition to the benzodiazepine hypnotics, more recently, the non-benzodiazepine hypnotics have been introduced. Drugs in this class are zolpidem, zaloplan, and azopiclone. These drugs act at the BZ1 receptor subtype. That is, these are the benzodiazepine receptors that have the alpha-1 subunit. And these drugs can be reversed by the use of flumazenil. Their main clinical indication is insomnia. Their toxicities are things like ataxia, headaches, confusion. These tend to have a short duration because of the rapid metabolism of these drugs by liver enzymes. Unlike older sedative hypnotics, these drugs cause only modest day-after psychomotor depression and have few amnestic effects. They also have a lower dependence risk than the benzodiazepines, and for these reasons have become quite popular. Anesthetics. There are certain principles that are common to the use of all general anesthetics. First of all, these drugs have to get into the brain. Therefore, drugs that are more lipid-soluble have an easier time getting into the brain, and therefore tend to have a higher potency. In addition, drugs that have a low solubility in the blood tend to have a faster onset and offset than drugs that have a high solubility. And the reason is that drugs that have a high solubility takes a longer time for those drugs to reach steady state than drugs where only a small number of molecules can actually dissolve in the bloodstream. Drugs that have a high solubility in lipid tend to be very potent drugs in terms of their effects on the brain. One way of expressing potency of an anesthetic agent is what's called the MAC. The MAC is the minimum alveolar concentration, and this reflects the amount of anesthetic it takes to effectively anesthetize 50% of the population. The lower the MAC, the higher the potency of the drug. And the lipid solubility, therefore, will be inversely proportional to the MAC, meaning a high lipid solubility will give you a low MAC, which is a way of stating that the drug has a high potency. So, for example, nitrous oxide, or N2O, has low blood and low lipid solubility. Because of its low blood solubility, it will be a fast inducer of anesthesia. However, because of its low lipid solubility, it will do this with a very low potency, and therefore a relatively high dose is required. In contrast, halothane has a high lipid and high blood solubility. Therefore, it is a very potent anesthetic, but its onset of action is slow. Three factors that impact the efficacy of gaseous anesthetics are lung physiology, blood solubility, and tissue factors. For example, increases in the rate or depth of ventilation will increase the partial pressure, also known as the gas tension, of an anesthetic gas. In addition, increases in blood solubility, as measured by the increase in the blood-gas partition coefficient, will increase the amount of gas required to saturate the blood, which will produce a slower time to reach a given efficacious concentration. Finally, if there is an increased arteriovenous concentration gradient, this will increase the amount of gas required to saturate the tissue, which will again produce a longer time to reach a particular efficacious concentration. Inhaled anesthetics. There are multiple inhaled anesthetics, such as halothane, enflurane, isoflurane, sevoflurane, methoxyflurane, and nitrous oxide. Unfortunately, at this point, we don't understand the mechanisms of how these drugs work. They do have some characteristic side effects. Many of these drugs cause myocardial depression, respiratory depression, nausea and emesis, and increase cerebral blood flow, which can diminish cerebral metabolic demand. Certain of these drugs can be quite hepatotoxic. One of them that can do this is halothane. Methoxyflurane is known to be nephrotoxic. Enflurane is known to be a proconvulsant drug. Malignant hyperthermia has been associated with many of these drugs, and the most common associated would be halothane. And nitrous oxide can cause expansion of trapped gas, causing disorders such as a pneumothorax. There are also intravenous anesthetics, and some of these drugs we're already familiar with from our discussion of anticonvulsants. For example, barbiturates. Barbiturates can depress the nervous system, therefore can act as potent anesthetics. Thiopental is a very potent barbiturate, with a very high lipid solubility and rapid entry into brain. It has been used in the past quite frequently for induction of anesthesia for short surgical procedures. The effect is terminated by rapid redistribution into tissue and fat. This drug can also decrease cerebral blood flow. Benzodiazepines can also be used for the same indications. Fast-acting benzodiazepines like midazolam can be used for short procedures like endoscopy. They're also used adjunctively with gaseous anesthetics and narcotics because they can lower the doses needed of those other drugs. These drugs may cause severe post-operative respiratory depression, and they can drop blood pressure. Both of these can be treated with flumazenil. These drugs can also induce anesthesia. In addition, the aryl cyclohexamines like ketamine can be used. These drugs are PCP analogs that act as dissociative anesthetics, and they work by blocking NMDA receptors. They can also stimulate the cardiovascular system. Their major side effects are disorientation, hallucinations, and severe, vivid dreams. The dream side effect tends to be most potent in adults and less potent in children. These drugs can also increase cerebral blood flow. Opiates, such as morphine and fentanyl, are typically not used by themselves as anesthetics, but are often combined with other drugs to induce anesthesia. Finally, propofol. Propofol has become extremely popular and has replaced thiopental, primarily, for the use of induction. These drugs have a rapid onset of action and are commonly used for short procedures and cause less post-operative nausea than thiopental. It's not entirely clear how this drug works, but it probably acts by potentiating GABA-A synaptic transmission. One way of remembering these 5 classes of drugs is the mnemonic, B.B. King on opiates proposes foolishly. Local anesthetics. There are 2 broad chemical classes of local anesthetics, esters and amides. Fortunately, the names of these drugs give away their class. For example, local anesthetics with the letter I in their name, excluding the cane suffix, are amides, and the rest are esters. Mechanistically, these drugs all work by blocking sodium channels by binding to specific receptors on the inner portions of the channel, and they preferentially bind to the activated sodium channels, so they are most effective in rapidly firing neurons. The tertiary amine anesthetics will penetrate the membrane in the uncharged form and then will bind to the ion channel when back in the charged form. One important principle here is that in infected and acidic tissue, the alkaline anesthetics are charged and therefore cannot penetrate the membrane effectively. Therefore, a higher dose is required to get the same level of efficacy. Another important principle is the order of nerve blockade. These drugs will block the small diameter fibers before the large diameter fibers and will block myelinated fibers before they block unmyelinated fibers. Overall, however, the size factor is a bigger factor than myelination. Therefore, these drugs at moderate doses will primarily affect the small fibers first, and then gradually will begin to pick off larger and larger fibers. Therefore, the order of loss is pain first, then temperature, then touch, and then pressure, which is good because we don't want our local anesthetics to block all neurotransmission, just the pain neurotransmission. And except for cocaine, these drugs are often given with vasoconstrictors like epinephrine to enhance local action. This will diminish bleeding, and it will make sure that the drug does not go into the systemic circulation. Cocaine has its own sympathomimetic properties, and therefore you do not need to add an additional sympathomimetic like epinephrine. Clinically, these drugs are used for minor surgical procedures. They're also used for spinal anesthesia. And if a patient is allergic to esters, one can give them an amide-based drug. The major toxicities for these drugs are CNS and cardiovascular. They can cause CNS excitation. In high doses, they can also cause CNS depression. From a cardiovascular perspective, they can cause toxicity by causing arrhythmias. They can also cause hypertension or hypotension. Neuromuscular blocking drugs. Paralysis is necessary for patients who are going to the operating room who are going under general anesthesia. This will help facilitate mechanical ventilation. The drugs that are used for neuromuscular blockade are drugs that will affect the nicotinic receptor and are selective for the nicotinic receptor at the level of the neuromuscular junction. And these drugs come in two broad classes. One class is the depolarizing class of drugs, of which there's only one drug in this class, and that's succinylcholine. The second class is the non-depolarizing class of drugs. Succinylcholine will work by depolarizing postsynaptic skeletal muscle and not allowing repolarization of that muscle for some protracted period of time. The complications of this drug include hypercalcemia and hyperkalemia. Blockade at the level of the neuromuscular junction can be reversed in two different phases. During phase 1, which is a prolonged depolarization phase, there is no antidote. In fact, if one were to use a cholinesterase inhibitor, the neuromuscular blockade would be potentiated. During phase 2, when the cells have been repolarized but blockade remains, the antidote would be a cholinesterase inhibitor such as neostigmine. The non-depolarizing agents are all derived from the natural product curare, and these are drugs like tubocurarine, atracurium, mivacurium, pancuronium, vecuronium, and rocuronium. All of these drugs are competitive antagonists for acetylcholine at the nicotinic receptor at the neuromuscular junction. The reversal of the blockade is relatively straightforward. One can use a cholinesterase inhibitor like neostigmine or edrophonium to increase the levels of endogenous acetylcholine to compete away one of these blocking agents. Dantrolene can be used to treat malignant hyperthermia. Dantrolene works by blocking the efflux of calcium from the sarcoplasmic reticulum into the cytosol of skeletal muscle cells. So in clinical states where there is runaway excitation of skeletal muscle cells, such as malignant hyperthermia or neuroleptic malignant syndrome, dantrolene can be effective in slowing down muscular contraction, and this will also decrease the temperature of the patients. Malignant hyperthermia is seen often in the combination of inhaled anesthetics except for nitrous oxide and succinylcholine. The main neurochemical alterations in Parkinson's disease are a drop in dopamine levels as well as a rise in acetylcholine levels in the corpus striatum. So the drugs used to treat Parkinson's disease are designed to either elevate dopamine levels or to diminish muscarinic cholinergic signaling. So for example, there are multiple drugs that act as dopamine agonists like bromocriptine, pergolide, which is an ergoalkaloid and a partial dopamine agonist, pramipexole, ropinirole, which is a non-ergo drug. The non-ergo drugs are preferred. So the side effect profiles, for example, of pramipexole and ropinirole are much better than drugs like pergolide. Another approach is to increase dopamine levels. This could be done with a drug like amantadine. Amantadine also has another set of indications, which is to be used as an antiviral. This drug is used against influenza A and rubella. The major toxicity of amantadine is ataxia. By far, the longest track record of success in Parkinson's disease belongs to the combination of levodopa-carbidopa. Levodopa is converted into dopamine in the CNS and therefore serves as a dopamine replacement strategy. Another approach is to prevent the breakdown of dopamine with drugs like selegiline, which is a selective monoamine oxidase type B inhibitor, or entacapone or tolcapone. These drugs are COMT, catechol-O-methyltransferase inhibitors, and these drugs will prevent the degradation of L-dopa and dopamine, thereby increasing dopamine availability. As mentioned before, acetylcholine activity is increased in the setting of Parkinson's disease, so anticholinergics, particularly antimuscarinics like benztropine, can be used. These drugs are primarily targeted towards improving tremor and rigidity, but have little effect on the bradykinesia. As a point of reference for other forms of tremor like essential tremors or familial tremors, one could use beta blockers like propranolol. Some mnemonics to help you remember these drugs will be balsa for bromocriptine, amantadine, levodopa, of course with carbidopa, selegiline and the COMT inhibitors, and antimuscarinics. And of course, to recall that benztropine is an anti-Parkinsonian drug, you can use the mnemonic park your Mercedes-Benz. As mentioned before, levodopa-carbidopa has a long track record of success in Parkinson's disease. Its mechanism is to increase the level of dopamine in the brain. You can't just give dopamine to patients because dopamine will not cross the blood-brain barrier, but levodopa will. And levodopa is then converted by dopa decarboxylase in the central nervous system to dopamine. The main clinical use of this drug is to treat Parkinsonism. The major toxicities are arrhythmias from the peripheral conversion of L-dopa to dopamine. And with long-term use, these drugs may precipitate dyskinesias. Ultimately, these patients who have dyskinesias may have dyskinesias associated with the peak dose and then akinesia between doses. Carbidopa must be given with levodopa to prevent the conversion of levodopa to dopamine in the periphery. If this were to happen, most of the drug will not make it into the brain. In addition, this limits peripheral side effects because high amounts of dopamine in the periphery could lead to arrhythmias and could also cause a substantial amount of nausea. Selegiline. Selegiline is an MAO-B inhibitor, and as mentioned before, MAO-B is one of the enzymes that breaks down dopamine. So by inhibiting this enzyme, dopamine levels will be increased. MAO-B is more selective for dopamine than it is for norepinephrine and for serotonin. Therefore, this drug is more selective for dopamine than it is for other neurotransmitters. Clinically, this drug is used as an adjunctive agent, often coupled with carbidopa-levodopa for the treatment of Parkinson's disease. One toxicity here is the drug, by elevating levels of L-dopa and dopamine, may enhance the adverse effects of those drugs. Alzheimer's disease. One of the main neurochemical deficits in Alzheimer's disease is acetylcholine. Therefore, drugs that elevate acetylcholine levels, like the acetylcholinesterase inhibitors, can be very useful. Drugs in this class are donepezil, galantamine, and rivastigmine. Their major toxicities are associated with the high levels of acetylcholine that they produce. So these patients can have nausea, dizziness, and insomnia. In addition, memantine, whose mechanism of action is to act as a non-competitive antagonist to the NMDA receptor. This drug may prevent excitotoxicity, which is mediated through calcium flux through the NMDA channel. The drug has been used for Alzheimer's disease, is primarily used for later stages of Alzheimer's disease, and the major toxicities of this drug are dizziness, confusion, and hallucinations. For Huntington's disease, there are no FDA-approved drugs. We know that the disease involves a functional increase in dopamine levels and decreases in GABA and alterations in acetylcholine physiology. Therefore, amine-depleting drugs like reserpine and tetrabenazine have been used successfully here. Haloperidol, a dopamine receptor antagonist, has also been used successfully to treat the symptoms in Huntington's disease. Sumatriptan. The most successful class of anti-migraine drugs today are the triptans, and sumatriptan is the prototypical drug in this class. Sumatriptan is a 5-HT1B/1D agonist and will cause cerebral vasoconstriction, will also inhibit trigeminal activation and vasoactive peptide release. The drug has a very short half-life, less than 2 hours. The drug is typically used for acute migraine, and the drug can be given both via an injectable and an oral form. It's also used for cluster headache attacks. Because the drug is a vasoconstrictor, the major toxicity here is coronary vasospasm and is therefore contraindicated in patients with coronary artery disease or Prince-Metal's angina. The drug can also cause mild tingling. One way to help remember the indication for sumatriptan is the mnemonic, "A sumo wrestler trips and falls on your head." That concludes the neuropharmacology section of First Aid Review brought to you by Falcon Physician Reviews. This also concludes the overall First Aid Neuro Review brought to you by Falcon Physician Reviews.